Hi, I'm John Kelly. I'm going to go over Chapter 3 in our 7-part series on vulnerable adults now. If you have questions during these chapters, please let me know, but I want to cover today in Chapter 3 injuries, red flags, and the silent catastrophe of facility neglect. If you're watching this, it's likely that you're seeing something that doesn't sit right. An injury, a sudden change, a pattern of decline, and you're looking for clarity. In this chapter, we'll talk about the most common injuries and red flags in vulnerable adult abuse and neglect cases, and why these injuries often tell a story even when the person cannot. I'm here to help you understand and navigate what can feel overwhelming. In the last chapter, we defined the types of care settings and why the label on the door doesn't control the duty. Now we're going to look at the physical evidence, because in these cases, the body is often the witness. That's one of the cruelest parts of vulnerable adult cases. The person who knows what happened may not be able to describe it. They may have dementia, they may be nonverbal, they may be afraid. They may have been told directly or indirectly that speaking up will make things worse for them. So you have to learn how to listen to what the body is saying. So let's now walk through the major injury categories. Pressure injuries or bed sores. The signature of missed care. Pressure injuries are one of the clearest red flags in facility neglect cases because they are often preventable with very basic and consistent care. A pressure injury is tissue damage caused by unrelieved pressure and impaired blood flow. When the pressure stays too long, especially over bony areas like the sacrum, heels, hips, and ankles, skin and underlying tissues start to die. Families often first notice redness that doesn't go away, a blister, a dark purple area, or a wound that just looks deep and serious. Clinically, pressure injuries are staged. You'll hear words like stage 1, 2, 3, 4. Here's a plain language breakdown. Stage 1 is usually intact skin with persistent redness. Stage 2 is partial thickness, often like a blister or shallow open wound. Stage 3 is deeper, full thickness tissue loss. This can look like a crater. Stage 4 is the worst, deep tissue loss, sometimes exposing muscle, tendon, or bone. You may also hear unstageable, which is covered by dead tissues so the depth can't be seen, or deep tissue injury, which is dark discolorization signaling deeper damage beneath the surface. Now, an important concept to go over. A deep pressure injury is rarely a surprise event. It's usually the end of a process. So there's prevention basics, and they include regular repositioning for bedbound residents, offloading pressure, especially the heels, keeping the skin clean and dry, managing the moisture from incontinence, nutrition and hydration support, and early intervention when redness appears. So when you see an advanced pressure injury, it's fair to ask, was the turning schedule followed? Were the skin checks documented? Were incontinence and moisture managed? Was the resident assessed as high risk? Was the care plan updated when risk increased? Was wound care started promptly and appropriately? If you're a family looking at this is where the record tells the truth. The Braden risk scores, if documented, turning the positioning logs, if they exist, wound measurement trends, treatment orders, TAR entries, and timing of when the wound was first charted compared to when the family first started it is what attorneys like myself will be looking at. And if there's a sudden jump, skin intact 1 week, stage 4 the next, be alert. Sometimes that jump is negligence. Sometimes it's documentation failure. Sometimes it's chart manipulation. Your job is to find out which. And your attorney should be able to help you with that by ordering the records and evaluating it. Malnutrition and dehydration, the slow emergency. Weight loss is often earliest sign that care is slipping. Malnutrition isn't just they didn't feel like eating. In facilities, malnutrition often results from the meals are delivered but not assisted. Food is too difficult to chew or swallow safely. The lack of supervision for someone who forgets to eat, depression or medication effects, or simple neglect. Sometimes trays removed untouched day after day. So dehydration is the twin of malnutrition. A vulnerable adult may not feel thirst normally. They may not be able to access water. They may not need reminders or help to drink water. They may avoid drinking because they're afraid staff won't help them to the bathroom. Dehydration can trigger constipation and then UTIs, delirium, often falls and kidney injury, and a general crash in resilience. Family-facing red flags include if they have loose clothing, sunken appearance, a dry mouth, fatigue, they have new confusion, dark urine, and repeated little infections that keep coming back. So for attorneys like myself, the evidence often includes weights and how often they were taken, intake records, dietitian notes, swallow evaluations, care plans for feeding assistance, and very importantly, whether the changes were escalated to a physician and communicated to the family. Now we'll go over falls and fractures. Falls are common, but serious falls are often a pivot point where a vulnerable adult's life changes permanently. A hip fracture can be catastrophic. Even when surgery goes well, the aftermath often includes immobility, pain, delirium, infection risk, blood clots, pneumonia, and sometimes permanent loss of independence. A fall can also cause a head injury, a subdural bleeding, concussion, cervical spine injury, in frail adults, even a simple fall can become a long hospitalization. In a prolonged rehab stay and rapid decline can often follow. The legal and clinical question is not only did they fall, it's was the fall foreseeable and were the reasonable precautions in place to prevent it? There are common facility-related contributors, and they include unanswered call lights, missed toileting schedules, inadequate transfer assistance, poor supervision after medication changes, clutter or poor lighting, unsafe footwear, and failure to use appropriate alarms and mobility aids. We'll also talk about medication errors and chemical restraint. Medication errors can be obvious. They give the wrong drug, the wrong dose, but chemical restraint is often quieter. Chemical restraint is when medication is used primarily to control behavior rather than to treat a legitimate medical condition with appropriate monitoring and consent. Families will often describe, she's sleeping all the time. He's not interested in anything anymore. He seems foggy, like he's not here. She started falling right after the new medication. Medications that commonly raise concerns in these settings include sedating, antipsychotics, benzodiazepines, opioids, and combinations that amplify sedation. This is where the PRN usage matters. This is where the timing and med changes compared to the falls and decline matters. So as an attorney evaluating these, the question is, when was the medication started? Who ordered it? Was there a behavioral assessment? Was the consent obtained if required? Was there monitoring for side effects? Was the medication used as substitute for staffing? Now I want to talk about aspiration pneumonia. When swallowing risk is ignored, aspiration pneumonia is a common and often preventable cause of death in vulnerable adults. Aspiration happens when food, liquid, or saliva enters the airway and lungs. A person with dysphagia may cough while eating, pocket food, choke, or have wet vocal quality. Facilities are supposed to respond to swallowing risk with swallow evaluations, diet texture modifications, thickened liquids when necessary, upright positioning, slow feeding, supervision, and good oral care. Oral care matters because bacteria in the mouth can become the bacteria in the lungs. Neglecting oral hygiene can increase aspiration pneumonia risk. Families often will hear, they just got pneumonia, but sometimes just pneumonia is the end of a long chain: ignored choking episodes, poor supervision at meals, missed swallowing precautions. Now I want to talk about UTI, infection, and sepsis. The cascade. Sepsis is not a fancy term. It's the body's emergency alarm system going off and sometimes shutting down. In vulnerable adults, infections often begin quietly. A UTI, a wound infection, an untreated respiratory infection. Early signs of this can be very subtle. There could be new confusion, lethargy, reduced appetite, or fever, or low temperature, rapid breathing, rapid heart rate, weakness, or not acting like themselves. In a well-staffed setting, those changes prompt evaluation and escalation. In a poorly run setting, those changes get charted and watched until the resident crashes. If you're a family member, this is where you trust urgency. Sudden change in mental status is not something to monitor for a day or two. It's something to evaluate now, especially if the person is frail. As an attorney, looking at these, we look for vital sign trends, nursing notes about confusion, delays in contacting a provider, gaps between the symptoms noted, and hospital transfers. I'll now talk about physical and sexual abuse. The injuries and fear abuse is real in care settings and is often underreported. Physical abuse can show up as bruises in unusual locations, inner arms, wrists, or torso, injuries with vague explanations, pattern of bruising or injury inconsistent with the resident's abilities. It can also show up as fear, flinching when approached, withdrawal, sudden agitation during care, or a resident pleading not to be left alone with a particular staff member. Sexual abuse can be even harder to detect, especially if the resident has cognitive impairment. Any concern about sexual assault should be treated with seriousness and urgency. Do not allow a facility to handle it internally. Emotional abuse is harder to photograph, but it's real. Humiliation, threats, isolation. Sometimes the resident can describe it, but sometimes they can't. Sometimes they can't, and their behavior just changes. Resident-on-resident abuse and violence is a known risk in memory care. Memory care facilities know this is a problem and exists. Aggression can be part of dementia, and some residents wander into other residents' rooms. Some become territorial or fearful. Some strike out. Facilities have a duty to assess and manage this risk. They have to do care planning, supervision, room placement, behavioral interventions, staff training, and separating residents when necessary. When the facility tells you residents just get into altercations, well, that might be true, but true is not the same as acceptable. If a resident is repeatedly injured, there's often a failure of supervision and planning. Elopement, the consequence of one open door. Elopement means leaving supervision, walking out. This is especially common with dementia and developmental disability. Risk factors include prior wandering, restlessness, exit-seeking behavior, confusion, and poor impulse control. Preventing elopement is not rocket science, but it requires systems. It has to have doors alarmed, secured, perimeters set up, staffing patterns that allow observation, and a care plan that treats wandering as a medical risk. When someone elopes, the questions are immediate. How did they get out? How long were they gone? What was the monitoring that was existing? Was the risk known? Was the family notified promptly? Was the law enforcement called promptly? Wrongful death pathways. How neglect ends in these cases. Death is often not a lightning strike, it's a predictable endpoint. Common wrongful death pathways include a fall that leads to a hip fracture, surgery, and then pneumonia or sepsis. A pressure injury becomes infected and progresses to sepsis. Aspiration pneumonia follows ignored swallowing precautions. Dehydration and infection spiral into organ failure. Medication or oversedation leads to a fall or aspiration. Elopement leads to exposure, trauma, or fatal injury. Assault leads to head injury or internal injury that is not timely treated. Understanding these pathways matters because facilities' insurers often try to erase the chain. They'll point the final event, pneumonia, sepsis, cardiac arrest, as if it came from nowhere. The final event usually has roots. Your job is to trace them back. Now let's end this chapter with another short story. Imagine a man in a memory care. Let's call him Mr. Johnson. He's a gentle person, but he wanders. His care plan calls for redirection and supervision, especially at night. One weekend, the facility is short-staffed, and Mr. Johnson wanders into another resident's room. That resident is confused and frightened. There's an altercation, and Mr. Johnson is struck and falls, hits his head. The facility tells the family it was an accident between residents. But the real question is, why was a known wandering resident unobserved long enough to enter another room? Why wasn't the environment controlled for predictable dementia behavior? That's not just unfortunate, that may be negligence. Now that we've discussed the injuries and red flags, we need to talk about what you can do both for safety now and for the accountability later. In the next chapter, we're going to move from medicine to action. How families can report concerns through APS, Adult Protective Services, the Ombudsman, licensing agencies, and law enforcement when appropriate. How to protect your loved ones while you create an outside record, and how attorneys build these cases, such as myself. Preserving evidence, identifying the right to legal theories, and proving what happened when the vulnerable adult cannot speak for themselves are important, and we will cover them. If you have questions after going through this chapter about a vulnerable adult and you would like to consult with someone, we have taken these cases throughout the nation and we're happy to give you a free consultation. You can reach us at 602-283-4122. It's the Kelly Law Team.